Welcome to the ACE Hot Topic webinar series. My name is Brian Mandreyer. I'm the ACE Executive Director. I have just a couple of ACE updates today to share with you before we get started. ACE is currently offering 2 meetings per year in addition to the webinar series that you're joining us for today. The first is the International Oncology Leadership Conference, which will be held in Rome from November 14th through the 16th. And registration will be opening later this month for IOLC. The second is our annual meeting, and this year, or the next edition of that, will be January 23rd through 25th of 2022. That meeting is going to be held in Charleston, South Carolina from January 23rd through the 25th. We'll have registration information available in late summer for that meeting. Both of these conferences are scheduled to be in person this year, which we are very excited about. And for more information on these events and membership information, you can visit cancerexecutives.org, and I will share links to those pages on the ACE website in the chat box during today's webinar. And now I have the pleasure of introducing our moderator for today's webinar, Nancy Bookbinder. Nancy is an ACE board member. She's the chair of the Member Services Committee, which oversees the webinar series. She's also the first recipient of the ACE Marcia Fountain Award for Excellence in Oncology Administration. And now I'd like to turn it over to Nancy.
I can't hear you.
Nancy, I think you're on mute.
I am, thank you. I'd like to welcome everyone, this time to participate in this webinar that is brought to you as part of the series of webinars of the Association of Cancer Executives for our membership. Goals of today's webinar are to gain learnings and guidance from our speakers as they address costs and benefits of an exercise oncology program in your hospital. And in addition to that, to hear from our participants. We really want to make sure you have the opportunity to ask questions. So after the presentation by our two speakers, you will have that opportunity. We request, however, that you don't wait till the end of the webinar, that as you have questions, you use the chat function and send them in. That way we'll have a sense of how many questions are coming in to ensure that we have enough time to get to your questions. I'm very pleased to introduce our two distinguished speakers today who will be talking about what I feel is a very important topic in oncology. Karen Wonders, and both of the women who are speaking today are PhDs, is the founder and CEO of Maple Tree Cancer Alliance and professor of exercise physiology at Wright State University. Her passion is to advocate for exercise as part of the national standard of care for cancer. Maple Tree provides free exercise training to thousands of cancer survivors every month at 43 clinical locations across the US, and it has been awarded Best in Dayton for health and fitness 7 years in a row, quite an accomplishment. Dr. Wonders is committed to evidence-based practice in her facilities and has a robust research program that has published 2 textbooks, 4 book chapters, and more than 70 peer-reviewed manuscripts on the topic of exercise and cancer recovery. Dr. Karen Smits is a distinguished professor of public health sciences at the Pennsylvania State University's College of Medicine. She's a clinical trialist who has led many exercise trials, including the PAL trial and Wiser Survivor, to be discussed during our presentation today. Dr. Smits has also translated the results of the PAL trial into clinical practice in a program titled Strength After Breast Cancer. She's also served as president of the American College of Sports Medicine. Dr. Smits chairs the Global Exercise in Medicine Governing Committee, and she is the founder of Moving Through Cancer Initiative of the American College of Sports Medicine, which has a mission of making exercise the standard of care in oncology by 2029. I'm very privileged to introduce these very distinguished speakers.
Thank you very much, Nancy. That was a very kind introduction, and I am absolutely delighted to be sharing the stage, if you will, with my dear friend and colleague, Karen Wonders. I'm going to show my screen, and I'm hoping that Nancy and Karen will let me know when we get to the point where you're seeing what I hope you'll be seeing. So I am asking to show screen. Is my screen showing at this point? It is, okay.
It looks like your
Is it,
email.
are you seeing the
There we go.
presentation now?
You're good now.
All righty, okay. The mysteries of WebEx, or GoToWebinar in this case. So, all right, so nice to be with you all this afternoon, and shout out to Leslie Watke, who I know is listening. So our presentation title today is Costs and Benefits of an Exercise Oncology Program in Your Hospital. I'm going to do the first part of the presentation, and then Karen will pick up and share with you some of the data from Maple Tree Cancer Alliance and describe the Maple Tree Cancer Alliance program to you. So first, though, a little bit of information that I think we all probably know about the impact of cancer in the United States. We know that there are 17 million cancer survivors alive in the US now, and this number is expected to increase by up to 22 million by 2030. So this is a growing population. It's currently 4% of the US population and will likely increase in its proportion of the US population with the silver tsunami, or the aging of the population. We also know that there are a number of side effects of traditional treatment, including physical, psychological, and financial effects of cancer treatment. The physical effects include a number of side effects that occur while people are undergoing their cancer treatment. These would include fatigue. Reports range anywhere from 80 to even as high as 95% of cancer patients reporting debilitating fatigue during their treatment. 70 to 80% of cancer patients report nausea, and 80% report edema. And finally, half of cancer patients report significant pain as they are going through their cancer treatment. There are also psychological effects of cancer treatment. 25% of patients report experiencing depression during their treatment, and 45% report experiencing anxiety during treatment. I want you to remember these numbers in particular as I share with you some of the benefits of exercise during and after cancer treatment. In addition, we know that there are a number of financial toxicities that are experienced by individuals as they are going through their cancer treatment, but there's also a huge impact of cancer on healthcare dollars that are spent within the US. We spend $200 billion on cancer care as of 2020, and that is expected to go up to $245 billion by 2030. We know that we can have better outcomes. We know that exercise could be useful for us to improve outcomes, including some of the effects that I have talked about, the physical, psychological, and fiscal issues that I've described so far. So the first thing I wanted to share with you all is the fact that there is a robust evidence base. So I actually did a search of what's called PubMed, which is where you go to look for the scientific evidence base. And there are now over 15,000 scientific publications in the area of exercise and cancer that are not reviews and that are based on human beings. And this is since 1965. The number of randomized controlled trials that have been done in the field of exercise oncology has grown exponentially in the period of time between when the American College of Sports Medicine published its first roundtable in 2010 and when ACSM held its second roundtable in early 2018. So we have a tipping point that's happening. It's time for us to start to pay attention to whether we have enough of an evidence base for us to shift our focus from whether we should be doing exercise for our cancer patients to how we should be doing exercise for our cancer patients. So in light of this, because we saw this evidence base, because we saw this increase, this exponential increase in the evidence base, the American College of Sports Medicine saw fit to hold an international multidisciplinary roundtable on exercise and cancer prevention and control in March of 2018, back when we all traveled, remember that? And we were very purposeful in getting all of the partner organizations in the room that are listed on this slide. The idea was that we wanted to make sure that we had all of the different constituencies in the room that touch the patient: medical oncology, surgical oncology, physical medicine and rehabilitation physicians, physical therapists, family practice docs, and we wanted an international audience as well, so that we would all speak with one voice. And so, in fact, we did have a tremendous list of partners listed on this slide, and you can see all of the people who were at the meeting in the picture in the center of the slide. The Beefeater is there because we held the meeting at the Sir Francis Drake Hotel in San Francisco. And if you've ever been to San Francisco, you know that there is always a Beefeater standing in front of the hotel. So we thought it would place us in time and space to have him with us. But you can see that we had the surgeons with us. We had NCCN with us. We had ASCO with us. We had the American College of Lifestyle Medicine with us, AAPM&R, CDC, CARF. We had Macmillan from the UK. We had ESSA from Australia. So we were really eager to speak with one voice and to examine the literature in a way that would reflect the robust nature of the evidence base that has developed in exercise oncology. The primary paper, there were 3 papers that came out of that particular roundtable, but one in particular that I want to describe to you briefly today are the results of that were in this particular paper, led very capably by Kristen Campbell and Carrie Winterstone, 2 of my friends and colleagues. And this paper was really a systematic review on 16 outcomes that are related to symptoms and cancer health related outcomes. So this one is not about, does exercise prevent cancer or does exercise prevent recurrence of cancer? We did do that, but that's not my topic today. I want to talk to you about what happened when this team of experts came together and did a remarkable job of a very, very deep review of the peer-reviewed scientific literature on whether exercise would help with symptoms as people were going through their cancer treatment. We did this with an eye towards what we call the FIT principle, which is frequency, intensity, time, and type. And I want to take a second to just describe and explain why that's important. Prior to this roundtable, when we told people to exercise during and after cancer treatment, we told them to exercise because we knew that there was some evidence that there was benefit to exercise, but we weren't able to tell people very specifically how frequently they should exercise, what intensity they should use when they exercise, how much time they should exercise each time that they exercise, and what mode of exercise, whether it should be resistance training or aerobic exercise or other types of exercise. What we really wanted with this review was to review the evidence so that we would be able to prescribe exercise like a medicine. We don't tell people to go get some chemotherapy the way that we might tell someone to go get some exercise. We're precise. We're precise with what type of chemotherapy we're giving, what the dose is, what the frequency is, the intensity. We give a fit prescription for our chemotherapy. We should be giving a fit prescription for our exercise oncology prescriptions as well. In order for us to do this, and there will be no quiz about this slide, and I know it's a great big branching tree, but I wanted to underscore the fact that this was not just a group of enthusiasts who believe in exercise deciding to say, well, yes, there's 5 papers, and so I've decided that there is actually evidence. We borrowed our decision tree from the Netherlands Physical Activity Guidelines, which had just been published just prior to when we started the systematic review. And so for each of 16 different symptoms, side effects, and cancer health related outcomes, we basically said, okay, are there any randomized controlled trials? If there were, we wanted at least 5. If there were 5, then we looked to see whether the effects of exercise based on those randomized controlled trials was relatively large, that it was not close to 0. If there was some effect, we then looked to see if there were 5 trials that they all show an effect, that would be a homogeneous finding. If some of them found an effect and some didn't, that would be heterogeneity in direction. And so with our branching logic moving from the left to the right side of this slide, what you can see is we come to the place of evidence where we say there's strong evidence, and we say, yes, we're making a fit prescription. We can tell people the frequency, intensity, time, and type of exercise needed in order to address this particular symptom during and after treatment, or a moderate level of evidence. Or there might be some outcomes for which we would conclude that we're not able to tell people that there is benefit. There might be some evidence, but it's not sufficient for us to draw any meaningful conclusions. And so just to cut right to the chase, we did this review within one paper for 16 different outcomes, and we found strong evidence that exercise has a positive effect on anxiety. 45% of patients report anxiety during treatment. Depression, 25% of patients report depression during treatment. Fatigue, 80 to 95% of patients report fatigue during treatment. Health-related quality of life, breast cancer-related lymphedema, and physical function. We found moderate level of evidence for bone health and for sleep. And there are a number of outcomes for which there was some evidence, but it was insufficient for us to draw any kind of conclusion with regard to our ability to give a fit prescription. The American College of Sports Medicine has been working really, really diligently to figure out how to communicate this information to patients, to caregivers, and to hospitals, so that we can have a greater likelihood of patients getting in front of a high quality exercise program during and after cancer treatment. As such, we have developed an infographic that you see in front of you here. This infographic is freely available at the Moving Through Cancer website, and which is literally, if you go to Exercise is Medicine, Moving Through Cancer, type those things into your Google search and you will find it. If you have any difficulty finding it, email me, I'll send it to you. It would be just, fantastic to get this in front of a number of people. We are seeking funding right now from a pharma company to print hundreds of thousands of brochures that would include this in order to educate patients and caregivers about the benefits of exercise during and after treatment. So to conclude the evidence base about the physiologic benefits and the symptom benefits, we believe that exercise is an emerging standard of care, that exercise is a valid rehabilitative measure that can be introduced at a variety of different points along the cancer care trajectory. It is safe, it is effective, and there have been, at this point, hundreds upon hundreds of clinical trials that have documented the effectiveness of exercise for symptoms during and after treatment. What I want to talk to you about for just a moment is a trial that we did at Penn State that speaks to what I think is now the big question in the field of exercise oncology, and that is not whether we should do this, but how. And so with the ENACT trial at Penn State, we answered the question, what would happen if we embedded an exercise professional directly into the chemo infusion suite? We were eager to do this to address 3 of the logistical and implementation issues in trying to get exercise into the hands of cancer patients: cost, referral, and location. Now, at Penn State, we do have something called the Exercise Medicine Unit, which is a 250 square foot exam room, basically. I don't know what's going on with my slides. It's located in the chemo infusion suite and is staffed by a full-time ACSM certified cancer exercise trainer. Now, that's fancy, that's great, and I know not everybody has that, but this can happen within the chemo infusion bays. This can happen in a conference room. This can happen, Karen will tell you that she's done this work in a stairwell. It doesn't take a whole lot of space to get this work done. Okay, so our primary outcome in the ENACT trial was whether or not this approach to trying to enact an exercise program during chemotherapy would be acceptable to clinicians and patients. We were also interested in the feasibility of the program, whether the patients would do the program. And we did a qualitative assessment of both clinician and patient perspectives to see, what do they say about it? Do they like it or not like it? And most importantly for today, given our particular topic, We also did a post-hoc analysis within our advanced cancer patients about healthcare utilization and the cost of hospitalization and emergency room visits in the advanced cancer patients that were a part of this trial. So we recruited for 18 months, and the way that we did this was we had a staff person who reviewed the medical records to identify potential subjects and review for possible contraindications using American College of Sports Medicine and American Heart Association guidelines for those contraindications. We then emailed the treating oncologist to get approval to approach, and then we approached patients at infusion visits. In addition, our exercise oncology professional had a pager, and physicians, if they were with a patient and realized, this person would really do well with this program, they could simply page the exercise oncology professional. By the time we were about 2/3 of the way into doing this trial, about half of our participants came from a page from the physicians. She just sort of became part of the furniture. So we had 807 patients who were possible to recruit. This was within solid tumor patients. We did miss a number of them, and we screened about 500. 82% of the possible patients who could have participated in the study were approved by the physicians, and 71% of those who were eligible and approached consented to be a part of the intervention. So that tells us that this was highly acceptable to both physicians and to patients. The exercise intervention that we did was highly individualized within a framework. Now that should sound familiar to those of you that are used to talking about chemotherapy regimens. Chemotherapy regimens are a framework, and they are then adapted according to what the particular patient needs. There might be 50% of this drug from what was originally prescribed and 80% of that drug, and it's individualized. So we did the same thing with our exercise intervention. There were 5 possible components: cardiovascular exercise, balance, strength exercise, stretching, and everyone was taught about productive rest and about the need to ensure that they were taking care of getting through their treatment first and foremost, that we were not doing anything that would impede the progress of their chemotherapy. We tried to work all of our exercise prescriptions towards the guidelines, towards what we believe is the best approach for everyone during chemotherapy, within the confines of understanding that if somebody had severe chemotherapy-induced peripheral neuropathy, we were not going to have them doing as much walking, for example. It was just perhaps going to be too painful. So the demographics for the study were that we had people who were on average close to 60 years of age. Over half of them were women. 94% were white, not surprisingly, given that I'm in central Pennsylvania. 75% of them had had a college education. Interestingly, 15% of them were still employed full-time at the point that they were doing chemotherapy. And the majority of them were consented by the 4th chemo visit, meaning that we caught them early on in their chemotherapy journey. In terms of clinical characteristics, the 3 largest groups of patients that were participants in this study were breast, GI, and pancreatic cancer patients. We had a smaller number of melanoma patients, and then about 25% fell into the other category. So there were 3 of this and 2 of that, kind of, a smattering of other tumor types. What I wanted to point out to you, given the fact that we did not have any adverse events, and given the fact that I'm going to show you the adherence data in just a moment, is the enriched proportion of chemotherapy patients at Penn State that are stage 3 and stage 4. These are advanced cancer patients, and these numbers are higher than what one might expect, except for the particular practice patterns in central Pennsylvania. We are sitting, kind of surrounded by a lot of rural territory, and so people come to us for their surgeries, and then generally speaking, the early stage, more common cancers will go back to their community oncology clinic for chemotherapy and or radiation treatments. And so the people who come to the Penn State Cancer Institute for their chemotherapy more likely are going to be more complicated patients and advanced cancer patients. So I did want to show you the exercise adherence data because I think it is really important to notice that several things. If I go across the top row, what you can see is that they did 70% of the aerobic exercise that we prescribed for them. They did 55% of the resistance training exercise we prescribed for them, 68% of the balance exercise, 63% of the flexibility, and overall, when we put all of it together for them, about 75% exercise adherence, which is actually quite good and certainly sufficient for us to see effects. What I think is really most important for me to communicate, based on what I said just a moment ago, is that we did not see significant differences in exercise adherence according to whether people were advanced stage or not advanced stage. So striking to me that the metastatic patients were just as able to do the exercise prescription that we were giving out as the non-metastatic patients. So now what I wanted to talk about very briefly is whether this exercise program that I've just described to you during chemotherapy alters healthcare utilization or costs. And the focus here is on the advanced cancer patients. And the focus here is on the advanced cancer patients because we did the analysis in the early stage patients as well, and we did not see the striking differences that I'm about to show you within the early stage patients. And the reason for that was because the early stage patients didn't use as much healthcare. So as a background, just to describe this, what I can tell you is that there is evidence in the literature that tells us that chemotherapy patients' yearly average is about 2 emergency room department visits and 1 hospitalization. And while there is variability in the published literature, it could be estimated that about half of emergency room department visits and hospitalizations are unplanned and possibly avoidable. So reducing those emergency room visits and hospitalizations is an oncology care gap that could be worth addressing. There have been some prior attempts to try to address this by virtue of asking about symptoms and having nurses give more intervention when paying better attention to symptoms. Those approaches cost over $2,000 per person during the chemotherapy. So the question was, could exercise reduce ED visits and hospitalizations during chemotherapy in advanced cancer patients? Now, I will note that this is a post hoc identification of matched patients, so this is not a randomized controlled trial, but we did look carefully at comorbidities, and our analysis does adjust for differences in comorbidities, which were negligible between our treatment group and our matched comparisons. We did a medical record review to look for all of the emergency room visits and hospitalizations. And first off, I think importantly, it's notable that our cost of our intervention was actually quite low. We had 2 different types of equipment that we tried in doing this intervention. And one of the ways that we used the equipment was more expensive than the other. So you can see that the range goes from $190 to $382 per patient, but the final average cost per patient was $191.68 for this intervention. Very, very low cost. I also want to point out the fact that the screening, we actually went back and figured out how much staff time it cost and thus what the cost was to screen these individuals, because that is such a barrier to making this sort of thing happen. And we discovered that it took, with our staff, $1 per patient for us to do the screening. And I thought that was pretty striking. So if screening is the reason why people aren't referring people into exercise interventions, it's $1 a patient. So I'm happy to share the methodology for that. So this is sort of the drum roll slide, if it'll come up. There it is. So what we have here is with a focus on stage 3 and 4 cancer patients. What I really want to point out to you is the number of emergency department visits. And you can see that the average was 0.48 in the individuals who were in the ENACT trial, who did the intervention, and the average in the matched comparisons was 0.65. More strikingly, the number of hospitalization nights, total nights stayed at the hospital in the ENACT patients was 1, and in the comparison patients was 2.5. So the final comparison that we can make at the end of the day is $11,000 from the payer's perspective, is $11,000 spent on emergency room visits and hospitalizations in per patient average in the ENACT patients who got the exercise intervention, and nearly $28,000 per patient average in the matched comparison patients. And this is after adjusting for any comorbidities. What I'll finish off with is just to note that this is not the only study that has been done that has looked at cost effectiveness of exercise oncology interventions. The majority of the published literature in this space has actually been done in the UK, in the Netherlands, and in Australia. And so ANIME in the Netherlands has shown cost effectiveness of an exercise oncology intervention, particularly for the more advanced patients. Hannah van Wart, also in the Netherlands, showed that a more intensive program, not just giving people a brochure, was more cost effective because it was more effective. And Louisa Gordon in Australia was able to document that a breast cancer rehabilitation program was cost effective as well. And with that, I am going to continue to manage the slides, but I'm turning the podium over to my friend and colleague, Karen Wonders.
All right, can you hear me?
Yes.
Oh, good. Okay. All right. Well, thank you so much, Dr. Schmitz. That was very interesting and hopefully got the attention of the people who are listening to the webinar. So I'm going to take this a little bit further and talk with you specifically about an exercise oncology program that I started called Maple Tree Cancer Alliance, and share with you some of the data that we have that has come out of the different patients that we have treated, and then just kind of share some information with you about how you might be able to get a program like this started in your own hospital. And so I want to kind of kick things off by sharing with you some more financial data. And this next couple of slides here that I'm going to share with you came from a third party that we worked with. Maple Tree Cancer Alliance is headquartered in the Dayton region, and all of the hospital systems in this region are a part of GDAHA, which is the Greater Dayton Area Hospital Association. And in GDAHA, they have a research arm called Ascend, and this particular research group has access to all kinds of patient information. And so basically, whenever we first started looking into analyses and healthcare utilization and does this actually save money for your patients, I went to them first and I said, you know, you're an independent third party. If I gave you a list of my patients, could you look and see if, you know, if before they enrolled at Maple Tree versus after they enrolled in Maple Tree, is there a difference? And so that's exactly what they did. We gave them a list of about 125 of our current patients, and they looked at their healthcare utilization in the 6 months prior to enrollment at Maple Tree, and then in the 6 months after enrollment at Maple Tree. So we gave them their start dates at Maple Tree, and they were able to track all that data for us. So this slide right here looks at the number of patient encounters that our patients had in the 6 months prior to enrollment at Maple Tree versus the 6 months after enrollment at Maple Tree. And what we found here was an average change of 2.06 fewer encounters following enrollment at Maple Tree, which was a significant decrease. This was about a 33% decrease from the 6 months before enrollment. And basically, this is attributed to a 6% decrease in inpatient hospital stays, a 19% decrease in the length of stay just overall for the patients, and a 27% decrease in ER visits. You can go to the next slide, Katie. Oh, that was my caption. You can go on to the next. Okay, thanks. And yeah, there you go. This one right here is the same patient population, but what we did for this is we looked at the number of readmissions for this patient population. And what we found was an average change of 1.93 fewer readmissions, so a 47% decrease in our patients from the time after enrollment compared to before enrollment. And then the next slide. The next slide looks at overall the total patient charges that we were able to measure, again, 6 months prior to 6 months after enrollment at Mapletree. And what we were able to find was an average total charge change decrease of about $2,800 after enrollment of Mapletree. So a significant finding for this as well. So significantly fewer healthcare costs associated with their treatments. And so to validate this study, this is some unpublished data that I'm sharing with you right now. We decided to do a randomized control trial, and we started with early stage breast cancer, as a kind of kickoff to this. And what we did was we had 123 women who were randomly assigned to an exercise group and 120 women who were assigned to a control group. And the women in the exercise model did our standard protocol, which I will get into in just a little bit, but it was 12 weeks of supervised, individualized exercise training. They did a full body workout with cardiovascular exercise, strength training exercise, and flexibility. And we assessed them at the beginning and at the end just to look for measures in improvements in fitness parameters. We also looked at healthcare utilization as well. The 120 women who were randomly assigned to the control group received the current standard of care at this particular hospital, which was just a handout with some, exercise guidelines and a few pictures for them. We also measured their fitness levels at the beginning and at the end of that 12-week phase as well. This slide right here shows what we found with the healthcare utilization. And so in general, we found that, on average, there was a higher number of total expenditures for the control group as compared to the exercise group. You can just kind of look down the list. This, was revealed with fewer emergency room visits, less inpatient hospital care, fewer outpatient visits, and then a lower number of total events over the course of the 12 weeks that we were looking at. And we're in the process right now of writing up this data, but I wanted to share it with you because I think that it supports the data that Katie shared earlier, and then also some of that retrospective data that I shared. And so basically what all of this information that we're throwing at you amounts to is what we call the impact of an exercise oncology program. And so you can see this slide right here shows an upswing. So when you engage your patients on an exercise oncology program, you're going to see an impact to their physical and their psychological health. All of this is data that we have collected at Mapletree, but we have found a nearly 60% increase in quality of life, a 15% increase in cardiovascular endurance, even in the middle of chemotherapy. We have measured these numbers here. An 18% increase in muscular endurance, a 31, almost 32% increase in flexibility, and an close to 80% increase in just feeling more positive, increased mood, less anxiety, all of those things. And again, this is in the middle of chemotherapy. I know cancer is not always gonna look this way for everyone, but it certainly is encouraging when you can point to the data that we have now on thousands of patients over 10 years and say that most of our patients do end their treatment stronger than what they were when they began. And those feelings of anxiety and worry, they tend to dissipate significantly. And that can be very motivating and encouraging for a patient to stick to their treatment regimen and do what they need to do to fight their cancer. The other end of this impact of an exercise oncology program is the financial impact. And I think that Katie and I have demonstrated in several different programs, not just Mapletree, but programs across the world, we have been able to see that patients who stay active during cancer treatment are going to see a reduction in their healthcare costs. So this is what we have measured here at Mapletree, but we have found a 6% decrease in inpatient hospital stays, a 19% decrease in the length of hospital stay, a 27% decrease in ER visits, and a 33% decrease in total patient encounters, and a nearly 50% decrease in number of 30-day readmissions. And when you put this together, when you look at the physical and the psychological impact and the financial impact, then what you get, what we call, is the exercise oncology effect. So it's kind of the difference between those two things. And with that being said, I just want to introduce you to my program, Mapletree Cancer Alliance. And just to give you a brief introduction about us, as I mentioned, we started here in the Dayton area back in 2011. And this model that I use came out of my doctoral work. I got my PhD at the University of Northern Colorado and studied under Dr. Carol Schneider, who was a founding researcher in this field, and had her blessing to adopt her model into my program at Mapletree. And since then, we have been able to develop partnerships with hospitals all over the country. We are in every single hospital in the Dayton and surrounding areas and have taken some steps to grow outward. So we also are partnered with UPMC, which is in Pittsburgh. We have several sites in San Francisco now because of a merger with Sunflower Wellness. So we are in UCSF and Stanford and Kaiser, and also in Florida, we do work with the Moffitt Cancer Center, and as I mentioned, UPMC in Pittsburgh. We also have 3 sites in Brazil, which was pretty exciting for me. I did not have a passport when I started Mapletree, so that was like the highlight of my life, getting to travel to Brazil and start a Mapletree there. And basically the way that our system works, you can go on to the next slide, Katie. Thanks. The way that our system works is I'm an advocate for individualized exercise programming. And so what that means is we will accept anyone at any stage, any phase of cancer treatment, you know, anywhere along the cancer trajectory. And depending on where that person is, we're going to categorize them according to these phases that you see right here. So we have a phase 0, which is a prehabilitation phase. That would include any patients who come to us from the time of their diagnosis until treatment begins. So sometimes we get a small window there where we can work with the patient and get them as strong as they possibly can before treatment begins. And we know, and research has shown, that if we're able to do that, then that will help improve their patient outcomes. From there, they go on to phase 1, which phase 1 would be someone who comes to us during chemotherapy or during radiation. For someone who's in chemo or in radiation, we exercise them at a much lower exercise intensity. And the reason for that is so that we can protect their immune system. And from there, they go on to phase 2. Phase 2 is for someone who has either completed chemotherapy and radiation, or maybe they just didn't need it, and maybe they just had surgery and hormonal therapy, and that's fine. With phase 2, we increase intensities just a little bit more, and we really work on educating the patient and getting them to improving their self-efficacy so that they can adopt a healthy lifestyle then for the remainder of their life. About 90% of the patients that we work with at Mapletree, when they come to Mapletree, were completely sedentary before their cancer diagnoses. And we want them to not only exercise during cancer treatment, which can be a tall order if you've never exercised before and now you don't feel great, but we want them to exercise during treatment, but then also beyond, because research would show that patients who continue to exercise will see lower cancer recurrence rates. So that's what we're trying to do. Phase 3 would be someone who has successfully completed phase 2, and we want them, we want them to be apparently healthy, which we don't have cancer specific exercise norms. And so if I put a cancer patient on a treadmill and measure their VO2, I'm going to compare that score to someone who's healthy. And obviously our patients are generally much, much lower than that of an average, healthy individual. And so our goal of phase 3 is to get them to that apparently healthy status. Ideally, they would be entering remission. And then, as I mentioned, they would continue to be active for the remainder of their life. Now, 97% of our patients, when they come to us, either enter as a phase 0, phase 1, or phase 2. Occasionally, we'll get someone who was just like, I just wanted to wait until my chemo was gone, or I just wanted to wait till I got into remission, and then they came to us, and we will accept them if we'll work with them. The components of our exercise program look very similar to that of any general exercise program. We have a pre-screening process where we have them fill out a medical history, a cancer history. We're talking to their physicians. We're getting as much information from them as we possibly can. From there, we go on to a fitness assessment, and the fitness assessment is just a series of tests that give us a baseline knowledge of that person. So we'll look at their cardiovascular fitness, muscular strength, muscular endurance, flexibility, and body composition. We also have them fill out some questionnaires. We look at quality of life, symptom severity, those sort of things. From there, and based on what we received whenever we did that fitness evaluation, we will then create their exercise prescription. And that is going to be individualized to that person based on their strengths and their weaknesses and their goals. From there, they go on to their exercise program, which is designed to last about 12 weeks, depending on their phase. If they're in chemotherapy, that's going to last 20 weeks. Well, then we'll probably keep them in phase 1 a little bit longer. But we meet with them once a week. They're each assigned their own individual trainer. We take them through a full body workout. It's anywhere between 45 minutes and 1 hour. At the end of that 12-week phase, we do a reevaluation, and that gives us that fitness data that I was able to report to you to show not only the patient, but also our hospital partners that these patients are getting stronger. They're seeing an improvement in their quality of life. Their anxiety is down. All of these positive things are happening as a result of their exercise program. And just to kind of close it out, I did want to share with you a patient testimonial. It's very short. It's less than 1 minute long, but it's one of our patients named Sally, who had been with us for a while. And so I'll just let you watch, and then we'll close it out. And Katie and I are happy to answer any questions. So Katie, you can go ahead and show that story. You should just be able to click it. I wonder if it won't work if we're in presentation mode, huh?
It's actually showing on my screen, but it's not showing on yours, huh?
Oh, no, it's not showing here.
Oh, how obnoxious. All right. Let's see what happens. Sharing. Stop showing screen. Now show screen. Now, what do you see now that I'm showing screen? You see Shelley?
The slide deck. No, I see the slide deck again.
I don't know that it's going to work.
This is Nancy. While we're trying to load, if you have any questions, please be sure to send them in.
Yep. Okay. I don't know that I'm going to be able to do it. I'm sorry.
Well, I will sum it up for you. Sally had a wonderful experience. And that was her lunch, her trainer she was given a high five to. And that was actually his last day. He moved with his family to Virginia, and they were going out to lunch right after that. It was a very sweet story. So yes, that's Sally's story. And here's my email. So anyone who's watching, if you want to reach out to me and ask how you might be able to join our network of clinical partners, we would love to talk with you. It's my goal to partner with as many hospitals as we possibly can, just to get cancer survivors and cancer patients moving. The last stat that I saw on this said that less than 5% of cancer patients exercise during cancer treatment. And I think that given all of the studies and all of the research that highlights the benefits of exercise, that we need to get that number much, much higher. That's my main mission in life. And so I'd love to work with you on that.
Catherine and Karen, I have a question. Any plan to move into the realm of radiation patients?
Yes.
Yes, we work with both. We work with radiation and chemo. That they would be a phase 1 patient as well.
Thank you. How about any surgical patients yet?
Yes, that would be a phase 2. Someone who just had surgery would be a phase 2 patient for us. but we will work with anyone at any point along the cancer trajectory.
Thank you so much.
Yes.
We do not have any questions in our chat box, but we strongly encourage people to reach out with any questions they may have. We'd like to very much thank Catherine and Karen for an excellent presentation, a lot of learnings, and we very much appreciate you taking the time to do this for the organization. We'd like to thank all the participants on the phone. ACE has a next offering is not actually a webinar, it is a workshop. And that workshop is going to take place in June, on June 16th. It's a 90-minute workshop. And the topic is Changing Your Oncology Leadership Career, COVID-19 and Beyond. Many of you know Julia Williams, as she has offered these workshops at our annual meeting. She is an executive consultant and advisor of JW Oncology. Many of you may know her from her recruiting activities. She's going to be joined in that by Derek Hare, Managing Director of Signal Hill Partners. You know, as members of our organization, the webinars are free to you. This is a little different as a workshop, and it's going to be offered as for $99. So we hope to see you there, and stay tuned for next upcoming webinars. Thank you so much.
Thank you.
Bye.
Thank you. Bye-bye.